Hello and welcome. Today, we will present our study, The Use of Bayesian Model for Diagnosing Ectopic Pregnancy, a classic that is good as new, a retrospective cohort study. The Diagnosing Ectopic Pregnancy is based on transvaginal ultrasound and serum levels of hCG. The Bayes Theorem gives us the probability that you have a disease, given the test is positive. It is seldom used in clinical practice, because it implies several calculations. An online calculator may be a solution for this problem. The objective of this study is to verify the performance of an online algorithm for diagnosing ectopic pregnancy. The algorithm considers the risk of ectopic pregnancy based on clinical data, the likelihood ratio of transvaginal ultrasound findings, and the discriminatory zone for hCG levels, both obtained from our institution, and the hCG variations between consultations based from the literature. The population studied was derived from a gynecological emergency unit in southern Brazil. All women who presented at the gynecologic emergency unit and underwent a transvaginal ultrasound for any reason were potentially eligible for this study. Those who had a confirmed diagnosis of pregnancy with a recent positive pregnancy test, either urinary or serum hCG, within 1 week. An electronic report of transvaginal ultrasound from our hospital database, and a follow-up with a pathology report or a clinical resolution of confirmed pregnancy, as the case of a previous ultrasound showing an embryo, and in the follow-up, the uterus was empty, it was considered as a case of spontaneous miscarriage. Those without electronic ultrasound reports, without follow-up, and with greater than or equal to 13 weeks of pregnancy, according to the last menstrual period and or by transvaginal ultrasound, were excluded from the initial analysis. All patients were followed according to standard care until a definitive diagnosis was obtained. Risk factors and clinical symptoms were obtained from patients' electronic records. Risk factors were based on our previous publication, namely, previous ectopic pregnancy, history of pelvic inflammatory disease, history of infertility, and history of tubal surgery. Clinical symptoms included the presence or not of pain with or without vaginal bleeding, or asymptomatic. From this database, we were able to calculate the pre-test probability of having an ectopic pregnancy, with and without risk factors, and according to signs and symptoms, from 2495 patients. Likewise, the performance of the ultrasound findings was calculated, based on 3,112 exams. The discriminatory zone was determined by considering only cases of pregnancy of unknown location that evolved to intrauterine pregnancy. In our study, the discriminatory zone was established as 2000. Next, the performance of the ultrasound findings was analyzed according to discriminatory zone. For instance, the likelihood ratio of the presence of adnexal mass, when the hCG is below 2000, is 13, but with an hCG above 2000, the likelihood ratio is 45. The variation of hCG values between consultations was obtained, and the likelihood ratio of these variations was applied, according to the literature. The online algorithm is represented here. We arbitrarily considered the threshold of less than 1% to rule out a case of ectopic pregnancy, while a value greater than or equal to 95% was considered a case of ectopic pregnancy. In the first consultation, the patient is asymptomatic and she does not have any risk factor. Her ultrasound shows the presence of free fluid, and her hCG is 400, below 2000. According to the algorithm, she has a probability of 6.95% of having an ectopic pregnancy. With this result, she is asked to return in 2 days. In the second consultation, she has mild pelvic pain and bleeding. Her ultrasound shows the presence of adnexal mass and free fluid, and her hCG was 360, a 10% reduction. With these data, her probability is very high, 99%. Our results revealed that the incidence of ectopic pregnancy was 8.5%. In most of the cases, adnexal mass and free fluid were the main ultrasound finding. A total of 6,102 ultrasounds were ordered as potential tests for the study. From these, 2,990 were excluded for not having the inclusion criteria, yielding 3,112 ultrasounds for analysis. These ultrasounds were originated from 2,495 patients. A total of 2,495 patients were eligible for the algorithm. 310 cases were excluded from the analysis. 27 cases of pregnancy of unknown location evolved to ectopic pregnancy. These patients were sent directly to surgery due to acute abdomen, hypovolemic shock, massive free fluid in the abdomen, and because the attending physician received an ultrasound report from outside the hospital that, combined with the ultrasound and HCG report from the hospital, made the diagnosis of ectopic pregnancy. After removing 310 cases, 2,185 cases were analyzed. From 2,185 patients in the first consultation, an ultrasound was performed. The algorithm defined 91 patients with an ectopic pregnancy and 1943 without it. The remaining 151 patients had a serum HCG. With the HCG results, 70 patients were considered as an ectopic pregnancy. The remaining 81 patients returned in 48 hours, and the same procedure was applied. The variation of the values of HCG between consultations was added, reducing even more the number of cases without a diagnosis. After the third consultation, the algorithm was not able to define one case, which was a spontaneous abortion. If we put these numbers in a 2x2 table, we have an accuracy, a sensitivity, and a specificity of 98.9%. Thank you for watching.